Good afternoon. Welcome, everyone. I'm Deborah Farrington, Deputy Secretary for Health for the North Carolina Department of Health and Human Services. We're going to wait just for another minute or so that all of the registrants will have an opportunity to join today's webinar. So we appreciate your patience as we just pause for another minute or so. Good afternoon again. I'm Deborah Farrington, Deputy Secretary for Health with the North Carolina Department of Health and Human Services. Thank you for your patience. We did have a few technical difficulties with some folks receiving the link for today's webinar in a delayed fashion, so we did want to wait for a few minutes to give folks an opportunity to join. We'll go through a few housekeeping items, but just want to say that today's session is an opportunity for the department to share with you where we are in preparation for the Rural Health Transformation Program. We want to share with you how your input is shaping our approach. We're very honored to have with us today Secretary Sangbhai, who's here to share some remarks and to set the stage for how we will go forward in formulating our application. We're also joined by other senior leaders within DHHS, including Deputy Secretary Jay Lovelam and Rachel Cooper, who's a project manager supporting the Rural Health Transformation Program. She's involved in the planning and the development of the state's application. If we can look just for a few minutes at some housekeeping items for today in the next slide. I just want to point out that a copy of today's slide deck will be available for you and a copy of the recording as well. That will be available on the department's website, so feel free to access the information there after today's webinar. A few other quick tips for attending this live event. Please note that the webinar has captions as well as subtitles. We're also providing today's information in Spanish as well. There's Spanish translation available. And we are asking you to please use the Q&A feature, which is in the top right corner of your screen, to ask questions or to provide comments for today's discussion. We ask that you include your name and your organization's name when asking a specific question. We will have a Q&A portion of this webinar towards the end, and we'll certainly try to get through as many questions as possible. And we will now happily talk just a little bit about what we're going to cover before we turn it over to Secretary Sangbhai. The next slide outlines big categories that we're going to address. But before I do that, well, let's go ahead. Secretary Sangbhai, before I go into some of those details, we'll have you provide your remarks.
Great. Thank you very much, Deborah, and welcome everyone. I think the level of participation that we have on this webinar and all of the participation we've had up to today is really demonstrative of the real interest everyone has in helping fix some of our rural challenges. You all know these. I'm just going to cite a couple of them to frame what we are working with in North Carolina and why I feel we are a credible applicant for this particular grant. We know that we're the second largest rural population in the country. We've had challenges with our rural hospitals. About a dozen have closed since 2006. About 40% of residents in almost 30 counties rely entirely on Medicaid for their health insurance. We know the workforce shortages are acute, and we have challenges with various forms of care, including maternal care. By some estimates, 500,000 people in the state live with heart disease, as well as diabetes and so on. And as I said, you all know all this, and we've heard from almost 200 individuals, organizations, rural health centers, FQHCs, advocacy groups on what we can do to make North Carolina succeed in the setting of all of these challenges that I just outlined. We know that this grant is going to be competitive. We also know that there are things that we are not going to be able to qualify for. This is really intended to be transformative. And I'm really excited by some of the proposals that we have seen from many of you that really talk about how do we change the way healthcare is delivered in North Carolina to create that sustainability, to create that idea that access should be available to all, that the kind of programs and services that people need are able to be accessed and are available readily, and that we don't end up incurring increasing cost and end up in a situation where we're spending more and getting less for healthcare. So I'm excited by all the things that we can do. This is going to be a very competitive process. It's a fairly robust application. And I think what we're going to be able to share with you today are the contours of North Carolina's submission. So with that, I'm going to turn things back to Deborah to get us through the substantive material for today's webinar. Thank you, everyone.
Thank you, Secretary Sangvi. We will cover today some background, and Secretary Sangvi set us off on a good foot with that, providing a bit of context for why this opportunity is important for North Carolina, why we feel like we're well positioned to qualify and implement the program. Rachel is going to talk a bit about some of the details of the Notice of Funding opportunity. We think that's important because we, as we've gotten interest in this funding opportunity, you can imagine that there's a wide range of interests and ideas that folks are putting forward. So we want to be sure to give as much detail as possible about what the grant actually requires. I'll talk a little bit at a high level about what North Carolina's approach is, how we get to a completed application and what key milestones we need to complete in the coming days and weeks. And then we'll talk about next steps and how we will be going forward. Next slide, maybe next two slides. This is one thing that I think our Deputy Secretary from Medicaid will help us address later as we address questions, but many of you know that this Rural Health Transformation Program is a part of the Federal Reconciliation Act, H.R. 1. And with H.R. 1, we saw significant changes being made to Medicaid that will reduce funding by almost $50 billion over the next 10 years. We know that rural hospitals across the country are going to see significant losses, and North Carolina has the potential to suffer greatly from the Medicaid cuts that were proposed as a part of H.R. 1. Specifically, North Carolina rural hospitals will see as much as a $3.7 billion reduction cut in Medicaid funds over the next 10 years. And so that's one of the reasons why this opportunity is really important for North Carolina. The Secretary talked a bit about how Medicaid and Medicaid expansion has been particularly helpful for North Carolinians. We've seen Medicaid disproportionately have benefits for rural North Carolina, and he talked a bit about the number of individuals in some of our rural counties who are enrolled in Medicaid. We also know that this Rural Health Transformation Fund is temporary, and so it won't completely address all of the gaps that we'll see in funding and in care, but it is a wonderful opportunity that we feel compelled to take advantage of to help us address some of the chronic care issues that Dr. Sangvi referenced earlier. It's going to give us a chance to build on what's working well in North Carolina. It's going to give us an opportunity to spur innovation and to implement some innovative strategies and to build on some innovations that have begun in North Carolina, but there have not been sustained funding available for it. So the Rural Health Transformation Program will give us an opportunity to address some of those things. It will be an opportunity for us to address the significant areas of deficit we've seen in workforce and our workforce shortages, and it's going to be an opportunity for us to start to address health outcomes and make improvements in that area as well. Next slide. I think I'm handing it over to Rachel to provide a brief overview of the NOFO. And so, Rachel, if you'll take it away.
Sure. Thank you so much, Deputy Secretary Farrington and Secretary Songbay. As Deputy Secretary Farrington mentioned, I'm Rachel Cooper. I'm a project manager with the Health Portfolio. I have the great honor of walking us through a quick overview of what's in the Notice of Funding. So let's get into it. The big picture is that the Rural Health Transformation Program is a $50 billion federal initiative created under H.R. 1. Each state is eligible to receive funding in the form of a cooperative agreement. And the funding is really split into two buckets. So the first bucket is a base of $25 billion that will be distributed equally among the states who apply. And then the second bucket is what they're calling workload-based funding in the Notice of Funding. And that is really broken into sort of three sub-buckets. And it's based on rural characteristics, the strength of our proposed initiatives that we include in our proposal, and certain policy commitments. So we'll get more into that, but we can do next slide, please. The program is grounded in 5 strategic goals. So the first is around making rural America healthy again. And so this means supporting access, supporting new access points and evidence-based interventions in prevention, chronic disease, behavioral health, and prenatal care. The second goal is around sustainable access. So that's really around helping rural providers become long-term access points by improving efficiency and working together across systems. The third is workforce development. So that's really around recruiting and retaining providers, including community health workers and others who can help patients navigate care. The fourth is around innovative care. So really supporting flexible models and payment mechanisms that can improve outcomes and reduce costs. And finally, tech innovation. So investing in digital tools, cybersecurity, and remote care to modernize rural health service delivery. Next slide, please. So this slide really recaps how states must use funds across different components that feed into those strategic goals. The NOFO says that we should use, or at least speak to 3 of the approved categories, although we're not limited by that. So these include workforce prevention, mental health, substance use disorder services, tech, and more. You can see all of them here. There's also some restrictions on this funding, and we'll get into that a little bit more, but at a high level, 20% cap for infrastructure, 15% cap for provider payments, and 10% for administrative costs. So we can do the next slide, please. So our goal in using these funds is to really ensure that they are transformative, that we're not duplicating existing services or covering routine operations. And I'm really curious with the amazing group that we have here today, what you all are thinking about these uses of funds. So we're gonna take a little poll. And so I'd like for you to just pull out your phone, scan the QR code, and we're asking you to vote to prioritize, which 3 do you feel we should strongly prioritize in our application? So I'll give you a minute or 2 just to get the form filled out, and then we'll see what the initial thoughts are. And just a tech note, if you're not able to scan the QR code, you can go to the link in the slide below, the menti.com link, and you can enter the code and it will bring you to the same place. And your feedback will really help us prioritize these investments for our rural communities across the state. Don't look at the results. Don't let other people influence your vote. But once you have voted, it's kind of interesting to take a look. I'll give people a minute or 2 to continue filling out the poll. All right. Can we refresh this? I think that might be helpful. I don't know if it's refreshing in real time. Great, great. Yeah, super helpful to see. So big priorities around prevention and chronic disease, workforce, mental health, substance use disorder, provider payments, a high priority, appropriate care, innovative care. You know, these really align well with the contours of how we're shaping up these initiatives. So exciting to hear that we are on target there. All right, we can go back to the slides. Thank you all. All right, so let's talk a little bit more about eligibility. As I mentioned earlier, only states can apply directly for RHTP funding, but we'll be working with a wide variety of partners as subrecipients as determined by the use of funds in our application. So you see here, HR 1 has defined a list of what they consider rural health providers. I think this is amongst a large list of potential partners that we might work with on this. And as I mentioned, it will be really determined by the use of funds referenced earlier. All right, so let's get to the next slide, please. All right, so what's not allowed? Let's take a moment to reflect on this. There are a couple of high-level buckets that I'll speak to. So funds cannot be used to replace Medicaid payments or cover services already reimbursed by federal programs. So a big part of this is mapping where there might be duplication and ensuring that what we're proposing here is not duplicative of what's already funded. There's no new construction allowed, only renovations that are clearly linked to program goals and that fall within that 20% cap. The prohibited uses include lobbying, meals, cosmetic procedures, certain tech purchases. EMR upgrades are capped at a 5% of the total value of what we receive. And then administrative costs, as I mentioned earlier, are capped at 10%. Next slide, please. All right. So now I think I'll turn it over to Deputy Secretary Farrington again to just walk us through where we are in terms of North Carolina's application and where we're going, and also some next steps in terms of where you can plug in and engage with us. Thanks.
Thank you, Rachel. So and you'll see this later when we go through the timeline slide. From the beginning, when we first heard about this opportunity, we started preparing for the submission of our application because we do know, although this is a temporary pot of money that will be distributed across 50 states, it is an opportunity for us to expand, to expand our mission, or at least to address some of the things that we've envisioned to address the needs of North Carolinians. And so we want to be able to support providers who are experiencing the kind of financial difficulties that we've referenced earlier, who are experiencing the direct cuts as a result of the changes in Medicaid funding at the federal level recently. We, in our application to CMS, intend to talk about how we're going to focus specifically on improving access to care, both in rural hospitals and for rural providers. When you look at the NOFO, there are numerous references to hub and spoke models or regional networks to address health outcomes. And so that certainly is heavily informing the approach that we want to employ going forward. Rachel already mentioned that there are references in the NOFO to using community health workers, to using peers in this setting, and using digital tools where possible to address health outcomes. So that certainly is going to be a key part of our application that we address going forward. Certainly, we want to focus on strengthening the rural health workforce. North Carolina is in an excellent position because, as many of you know, the General Assembly awarded North Carolina many $1 million over the last couple of years through our loan repayment programs. We want to build on the investments that the General Assembly has already made, but we want to take it to a different level. We want to look at professions or disciplines that were not included in that loan repayment program, And we're also looking at not just recruitment, but how can we retain providers in this area, and what can we do in the innovative space of not just having loan repayment programs, but finding ways to attract and keep providers in rural communities. So that will be a key part of our workforce initiative. Certainly a part of that will have to include something around telehealth, because we may not be able to completely address all of the needs through the attraction of workforce into rural areas. So we want to figure out how we can leverage technology innovations, how can we build on telehealth opportunities to make sure that we're addressing gaps that exist in many of our spaces, in the chronic disease space, as well as in the maternal health space. We want to foster provider partnerships, as well as partnerships with other community agencies. North Carolina has an excellent model in our Healthy Opportunities pilot. And although we don't have the funding that we need to continue to go forward, we certainly don't want to miss the opportunity to build on a model that has demonstrated success in North Carolina. And, you know, a key part of that initiative was partnerships and leveraging human services organizations across our state. So we want to focus in on our application about how we can expand those partnerships in our work going forward. And then we want to be able to improve health outcomes for rural residents. And so that's where we think we'll have an opportunity to take some very targeted programs and initiatives that maybe were funded or proposed in other ways. How can we build on those models that have been already sort of started or in an incubator mode? I will say before I go to the next slide, though, a key part of this initiative is we have to demonstrate as a state how we can sustain the efforts that are built as a part of the Rural Health Transformation Program. It is a 5-year program, a 5-year initiative, but we have to prepare for how these dollars can be leveraged to support innovation, to support digitization in some instances, but how can we sustain it? How can we look at addressing policy issues to make sure that the points that we put in place, or the parts of our system that we address, will be able to continue long past the 5 years of this initiative. Next slide. So thank you all for all of the feedback that you have given. We have received more than 210 comments so far. We do expect to receive additional input as a part of this process, but what you have provided so far has provided valuable input and will guide the direction that we take when we start to sort of refine what we're putting on paper already. What you've heard, what we've heard in the area of access to care is that folks want us to focus on mobile clinics, on, as I mentioned, using telehealth and expanding our use of telehealth across the state. Certainly transportation remains a challenge across our state, and folks have proposed ideas for how we might make improvements in that area. Behavioral health and addressing substance use will be a key part of our application, and it's a part of the feedback that we've heard from community members as well. I won't belabor the point on workforce development, but certainly you've provided us feedback in that area. And in the areas around technology infrastructure, broadband has been brought up as an area where we need to focus, as well as electronic health record interoperability, and looking at how we can have AI-enabled supports to improve access to care. And we've heard many options that you've proposed that we can consider as a part of this application as well. In terms of addressing what we'll call social drivers of health, you all have mentioned, and we agree with the need to address food, food insecurity, housing, and transportation also. And then finally, as I referenced earlier, in maternal and pediatric health, we have gotten specific recommendations around ways that we can address OB and GYN deserts, how we can address pediatric shortages, psychiatry shortages, and how we can begin to address those shortages through e-care or tele-OB options. In terms of regional highlights, we have heard a lot, and we've organized your feedback in buckets from Eastern, Western, and the Sandhills region. And you'll see on the slide some of the things that folks have shared with us from a regional perspective. In addition, I just want to highlight that folks have referenced some areas of concerns. Several partners have talked about the sustainability of rural healthcare and what we can do, how we can leverage these funds to make sure that not only are we implementing and promoting innovation, but that we're doing in a way that continues to expand and sustain the care that our rural citizens need. The other thing that we've heard folks talk about is make sure that our initiatives and how we craft this application prioritizes low cost, high impact solutions, recommending, and we agree that we will leverage technology to enhance our care delivery system. Folks have wanted to make sure that we direct funds towards programs that provide long-term benefits to rural residents. And they've also stressed the importance of community engagement, listening to the voice of rural residents, and making sure that the approach we leverage will be holistic. So now I'm going to turn to sort of what's the timeline? How do we get to a completed application? The next slide. What this timeline slide is intended to convey is what I referenced earlier. We've been working on this application, thinking about our approach, soliciting your input since late in July, early August. When the NOFO was released in the middle of September, we started to more formally kind of put some words on paper. And you've seen some of the feedback that we've got. We've started to organize some of our approaches around the major themes that we have received from you. The application for from North Carolina will be due on November 5th. It is our intent to submit our application towards the end of October. And I will note that we have already sent a letter from our governor to CMS. We did that at the end of September, stating North Carolina's intent to apply for this opportunity. Once we submit our application, CMS will have until the end of December to award the dollars to us, and then we will begin a application process, sort of a public process where providers will be able to specifically apply for the funds that we are awarded. You know that North Carolina has the potential to get as much as $200 million. We don't know yet how much we will be awarded, but the NOFO requires us to submit a budget sort of with a hypothetical amount of $200 million. So we will use that to frame our application, but the formal process for applying for these funds will begin at the early part of 2026. All right. I think we're ready to go to your questions. And unless there's a member of our team, Rachel, Dr. Greenblatt, Jay, or others of you who feel like we need to add something at the top to summarize something that we've covered or missed. If there's not anything, we'll next go to our Q&A, I believe.
Thank you, Deborah. Yeah, I have nothing to add. I've been listening carefully. I think you've done a really nice overview, and we're really delighted to have so much interest and support from our partners and stakeholders. Thank you.
Excellent. All right. So, Rachel, I'll ask that you come on camera. Are you on camera?
Yep, I'm here, and we've gotten a couple of questions that have come in already.
All right, and we'll just ask our other members of our team to be ready. We might pitch a question your way.
Okay, let's see. We have a couple of questions here. Would like to start with what are the metrics to ensure funds are spent well and goals are being met or not? That's from Fred Lewis, Carolina Forward. I don't know, Deborah, do you have some initial thoughts on that?
Well, what I actually would ask Rachel, can you talk just a little bit about sort of how the NOFO is organized? To his question, the NOFO requires that we sort of have pretty specific goals, that we have some well-defined metrics. But can you talk just a little bit about that to help him understand how we can best position ourselves?
Sure, and I would encourage folks to get into the NOFO. I think some of the questions here around sort of like uses of funds, I mean, those are really well described in the NOFO itself, but I think we're going to have to sort of braid together initiatives that will have projects underneath them, and each of those will have outcomes that we will speak to. Each of those initiatives needs to speak to those that 11 the list of 11 use of funds, as well as the 5 strategic goals that are articulated by CMS. So it's really about how do we kind of slice and dice this into initiatives that have pretty clear scoring criteria that's articulated well in the NOFO. So would definitely direct folks there for more specifics on that. And also just on a note on the NOFO, the annex has some great sort of example initiatives. So you can kind of see how CMS is thinking about how they want us to articulate. So again, it's high level initiatives and then kind of projects or activities that are described under those. Hope that helps.
Deborah. Rachel, I'll add, I think when we submit our application, Rachel described sort of, we'll align our initiatives and specific activities and projects within those initiatives to the goals that CMS has outlined in the application. And we'll have to be very specific. It's our intent to be very specific about what kind of health outcomes we're trying to achieve. And Dr. Greenblatt and I were speaking earlier, there will also be certain process outcomes that we are trying to achieve. And so our application will specify that. What do we intend to do in year 1 with regard to meeting with stakeholders or helping providers gain access to electronic health records, and how many providers do we intend to do that with? What kind of resources, dollars or otherwise, do we intend to put towards a particular type of rural provider? It's our hope that in year 1, we will have some key metrics that we can achieve to demonstrate some early wins and some early successes, because as this grant application is structured, our ability to receive dollars in years 2 through 5 is contingent upon how well we have achieved the goals that we outlined in year 1, what successes we have been able to demonstrate, and how well we've laid out our intention to change policy, or how if we're making progress towards those policy changes that we outline in our proposal. Certain policy changes obviously won't be possible to achieve until years 2 through 5, but in that first year, we need to sort of be clear about what are we going to do to start making incremental progress towards those changes, and were we able to successfully do that in year 1. Rachel, I'll turn it back to you for the next question.
Sure. Let's see. I think we answered Fred's question. I wanted to address a question from Patrick Brown from the NC Association of Local Health Directors. His question is around recipients, subrecipients who will be funded, how much they'll receive, and what they'll do. Will there be a chance for subrecipient applications and proposals based on broad goals for the department that the department applies for? So I think I'll take a crack at this, and folks can add on. My sense is that, we have initiatives that will pull in different types of partners, and that is an ongoing process. So right now is the sort of an initial phase of gathering that partner input and sort of fleshing out the types of partners we will be working with on this. So the time to give details about your funding priorities, how you see yourself fitting into it, is now, and I think it will be, and it will be ongoing. And so I would encourage you, if you haven't already, to submit through the feedback portal, and we'll put the link to that in the chat. I don't know if others want to add on to Patrick's question here.
This is Deborah. I think you're spot on, Rachel. I will say that the information that we've received, and Patrick, that you're able to provide, the more specific, the better, because although we have to submit some pretty high level information to CMS, we need to sort of use those building blocks to create an overall budget that will be a part of our application. And whereas we probably aren't going to put all those line item details in a specific application, we need to have those things roll up to a bigger budget ideal. And so we will have these initiative buckets, consider sort of building real regional networks as one potential bucket. Within that, we may have a number of projects that cost a variety of amounts of money, but we're going to roll those, $1 million, $500,000 initiatives up to that larger budget for that regional model, as an example. So any ideas you have are helpful for us, I think, because it helps us make sure that we're considering all the needs of rural North Carolina. How we formally sort of procure it, I think we are going to give more details about that towards the beginning of the year, but helping us to build a strong application for North Carolina is our first and highest priority right now. And your input is essential to that, because the care that members received is at the local level. I know I'm preaching to the choir, so to speak. And so we don't want to build a proposal at the state level that doesn't consider how people who are in local communities can actually improve care. So your details will help us craft that overall budget and proposal.
A similar question along those veins is, who are the community partners we're working with to develop the draft application? And I would say it's all of you on the call. It's anyone who submitted feedback via the portal and continues to do so. So we are actively monitoring that, synthesizing what we're hearing, and it is a great place for you to give input. Thanks.
Thank you, Rachel, for that. I will say, certainly we have heard from rural hospitals, we've heard from provider associations, we have heard from individual citizens, independent practices, we've heard from our community health centers, we've heard from our maternity health providers, so just and community-based organizations. So a wide variety of you have submitted input, and we are definitely wide open for it, interested in it, and just value it to a great degree.
Great. Another question from, I don't know who this is, but someone asked a question around workforce support. Are community health workers included? CHWs have long been essential in rural areas, providing vital support and promoting community health. Deborah, do you want to speak to that, or should we call on? Is there anyone else that wants to tackle that?
I wonder if Maggie's available to come on camera and talk about that, since there are many references to workforce in the application.
Yeah. So hello, everybody. It's wonderful to be here with all of you, and I will say that many of the proposals we've received have included community health workers as a way of reaching rural populations as part of those chronic care models and those wraparound services. So, we're not only does the NOFO call that out pretty consistently, but, the folks who are proposing providing this care at a community level have really included that in their models as well. So I think it's been well recognized as something, and certainly we want to be thoughtful about other kinds of considerations y'all might have about including that in a proposal.
Great. I also want to loop in Kelly Crosby with our Division of Mental Health, because I think she has some thinking on that as well.
Thanks, Rachel. Hey, everyone. Kelly Crosby, Director of DMH DDSUS, Mental Health, Intellectual Developmental Disabilities, and Substance Use Services. So Also want to add that certified peer specialists are a really critical part of our workforce as well. So we've seen a lot of input and applications, and we really support the use of certified peers, especially for those with mental health and substance use issues, as well as we have some new and exciting initiatives on working with community health workers and training them in mental health as well. So 100% aligned with Maggie. And I think we've got a lot of great feedback, and we very much support the use of community health workers and peers, and think this is a great opportunity to use this funding to bring in those vital components of the workforce.
Great. Thank you, Kelly. There was a question about, do we have a sense of how many subrecipients we want to work with and how the distribution or allocation will play out? Will it go to individual providers or networks? I think I would say we are shaping this out, and I would say that there's going to be more guidance on this as this process progresses.
Deborah, yeah, we haven't set a hard number. Were you able to hear me, Rachel? Yes, in response to that question, this is Deborah again. We have not set any firm or final number on the number of subrecipients or providers or organizations we will work with. One of the things I didn't highlight during the timeline slide is obviously with such a short period of time to develop our application, we're on working very quickly to put together our application. This webinar is sort of a part of the process to get us there, but you should anticipate that within the next couple of weeks, we will have sort of synthesized all the input that we've received. We're in fact going to ask you to get us that final input by October 10th so that we can kind of have, sort of feedback sort of at a stopping point so that we can get to the writing phase. And so it's during that process that I think we will start to get a lot clearer on the specific number of projects within each initiative area. But currently there is no hard number that we're working with. We won't get there until we have reviewed and made a final recommendation based on your input about how we're going to focus our application.
Great. And I think just to add to that too, acknowledging that what we're working with is the budget estimate. It's not any set or guaranteed amount. And I think that's another key point, that we will have more clarity on sort of the amount of funding, hopefully in December or January. I wanted to ask Maggie, there's a question about defining rural. So how do we know if we may be eligible as a sub-recipient or provider? And I know we've worked with some folks to help shape that out. Can you elaborate?
Yeah, so the NOFO and CMS is very specific about who they qualify as a rural health facility. And as you know, Shep Center at UNC is one of those folks who has been able to help us answer that question, not just for North Carolina, but for the nation. So they have gone through and looked at what would qualify. They're using the Federal Office of Rural Health Policy, rural definitions that were recently updated, and those were inserted into CMS NOFO. So we're happy to share any of that information that people are interested in, but it's very much specified in the NOFO who is a rural health facility and what those qualifications need to be. And those have been included specifically in the NOFO.
Thanks, Maggie. A question from Lashima Barr from the Carolina Complete Health. Are there plans to align this funding with other federal opportunities to extend its impact and ensure sustainability? I'll take a crack at that. Absolutely. And in fact, the NOFO instructs us to conduct what's called a duplication analysis to ensure that we're not duplicating, but we are building off of what already exists. And so I think that's absolutely part of our approach. Let's see. Just scanning. Thank you for all the questions coming in. This is great. Someone asked a question about the portal. How long it will remain open? October 10th. Let's see. Okay. This one I want to get maybe Larry's take on, and a few others. Have the proposed models included integrating physician's assistants, APNs, and pharmacists to expand access to care, leveraging the new expansions to their scope of practice?
I don't think we've specifically taken that on. I have some folks from the North Carolina Association of Pharmacists who are, they've scheduled a meeting with me for next week and want to talk about how pharmacists can play a role here. And there are some models of care that we're looking at using to improve care for substance use disorders and mental health conditions that will certainly be very much collaborative and cross specialties.
Deborah. Rachel, are you able to talk a minute? Because it seems like the NOFO does sort of place some weight upon the scoring for states who are willing to look at expanded scope of practice.
Right.
So to that point, I think if that's anything that we can do in that space, improves North Carolina's chance of receiving additional dollars.
Yeah. Yeah, and so we've gone through and sort of inventoried our baseline of sort of where we're at and what the proposal is by CMS of where they want to see, and we're sort of articulating, you know, what is our approach in North Carolina, and again, you know, it has to be feasible, it has to be sustainable, and we want to just make sure that we're also being transformative. So I think some of this question around scope of practice definitely plays in, and it will relate to you know, how we score in terms of the technical score factors. So yeah, and if you're curious and you want to nerd out on the technical score factors, there's a very detailed appendix in the NOFO that I would point people to, because it really does articulate how they're defining each of these both policy-based and state kind of actions for their evaluation. Let's see.
This is Deborah. I think there's a request to take the question on integrated care.
Sure. Do you want to go ahead?
No, you can
go. Okay. I'm
you just summarize it, Rachel.
Yeah, please go ahead.
So there was it's Kelly Crosby again from Mental Health, Developmental Disabilities and Substance Use Services. There was a question on integrated care, and of course invite Larry and anyone else to jump in. But obviously mental health and substance use is really important. It's important in rural areas, and care integration is really, really important. So we've got a lot of wonderful feedback, and we see a lot of opportunity to kind of expand and capitalize on some of the care integrations we've been working on in the state for a long time. Things like collaborative care, right, which is helping primary care docs treat mental health in primary care clinics. It involves virtual care, so I think it has that nice option too. We've got multiple virtual psychiatry products, like NC PAL, like NC STEP. So we think there's real opportunities to not only leverage them how they're being used, but maybe in other ways, to bring more psychiatry to rural areas as needed, or even other clinical services as needed. And we are very interested in, after a decade, figuring out how to expand our certified community behavioral health clinics. If you're not familiar with what a CCBHC is, imagine sort of an FQHC, but it's specifically for people with serious mental health and substance use issues. So it's very much about the continuity of mental health and substance use care, along with crisis services and physical health, either coordination or actual care. So we think that's an important part of these rural hubs. So we're getting care access at all ends of the spectrum, right? People with SMI and serious substance use disorder, and then folks who are going to primary care but need support. In that, I mentioned, really leveraging virtual opportunities. We've been doing that a lot lately in our space. And then I'll throw out one more thing, even though it's not, it is sort of an integration model, but folks have mentioned mobile clinics, and this is a great opportunity for us to really capitalize on our new law and authority to have mobile OTP clinics, so mobile outpatient treatment clinics for substance use disorder, for MOUD in rural areas. So that's a good opportunity for us as well. But Larry, you might want to add to that, by all means.
Thank you, Kelly. I'm realizing also I didn't introduce myself. So I'm Larry Greenblatt, and I'm the State Health Director. And I'm an internist by training. So I would say, Kelly, you certainly covered the huge lion's share of the integration efforts. I think there may very well be some maternity care integration into primary care settings because of the, so many counties really are really lacking in resources or have no maternity resources. And there may be some collaboration between OBGYN providers and primary care providers to allow for maternity care to be practiced in places that are more accessible to people. So that would be the last thing I would add to that.
Great. And I think there was a question about community colleges that was in the chat. I'm not sure if that got moved, but I wanted to make sure we covered it. Kelly Crosby, can I ask if you see that question? Can you tackle it? Let's see. Oh,
I haven't found it, Rachel, but I will use this as an opportunity to talk about something exciting and new that is in partnership. Well, I mean, our community colleges just rock, right? So they're already doing this, but there's a real opportunity, I think, for us to make sure that all community colleges have this degree, and we're working to kind of lift it up in our field. So you need the backstory. Unlike the medical field, we do not have certified nurses assistants, certified medical assistants. We don't have things like that. But what our wonderful community college system does is they have an associate's degree in human services, and it's a very practical and intensive study of either mental health or substance use. And it is a wonderful degree to kind of have an entry-level trained person in the workforce with the certification. So there's a really exciting opportunity, especially in rural areas, to leverage this course of study at community colleges to offer scholarships and then entry into the field. So creating that pipeline into the field is really exciting. And I think that's a nice complement to obviously some of the other things about loan forgiveness, but also sustainability of our licensed folks in the area. But we really do need well-trained entry-level folks, and we actually don't have that on the mental health and substance use side, maybe like the medical side does. So this is a real opportunity to leverage something that community colleges do extra well to build up entry-level workforce in rural areas.
I would add one thing to that also, Kelly, I didn't introduce myself either. Maggie Sauer, I'm the director of the Office of Rural Health. But I think, North Carolina has had a tremendous, we're recognized as having one of the best community college systems in the country. And I know that they have been key in working with the North Carolina Community Health Workers Association to train community health workers. I would also say that North Carolina has the North Carolina Center on the Workforce for Health. And that is an incredibly great opportunity for the state to come together, because it includes the chamber, community colleges, NCIOM, AHEC, SHEP Center, and a variety of other folks in the community that really are important to informing healthcare delivery opportunities. So I would point to that. And then the other thing is that there was a workforce panel that was put together by the folks, I think, in combination with the governor's office, and the community colleges were included in that. So there is some information about that feedback. But yeah, community colleges are really a critical part of how this gets done.
Okay, I think we have maybe space for 2 more questions. And sorry, we haven't been able to answer all of them, but again, please, submit any questions, thoughts through the feedback portal. Let's see. I wanted to touch on, there's a question about how will we ensure the needs of independent hospitals, those not in large networks? Let's see. Deputy Secretary Farrington, can you take that one?
This is Deborah. There are a couple of ways I think that we can make sure independent hospital needs are addressed in this application. One is we definitely want to hear from you as independent facilities about what your areas of need are. And if you have specific proposal ideas, please send those forward. We will make sure to drop in the Q&A, I guess is the way we would do it, or make sure that you know how to get in contact with us. The other thing I will say is that within our Office of Rural Health, we have staff dedicated to support rural hospitals, critical access hospitals, and they provide hospitals that are part of larger systems and support hospitals that are part of large systems and those that are not. So we've been working with the Rural Health Office of Rural Health team for a number of weeks to try to understand the data in this area, and also to make sure we're addressing our programs to meet their needs. So please let us know, but that's one thing that we're doing. Back to you, Rachel.
Great. Thank you, Deborah. One more, let's see, maybe one more question around how many of the priority areas will we be able to address in the application, and how will the areas be prioritized and determined beyond this polling? I think, the feedback form is where we're gathering information and insight and feeding that into the application. We're layering that on with, what the priorities are in the NOFO. I think there are a number of kind of guiding principles that we're using to try to get to what actually is housed under an initiative and what those activities are. Deborah, do you want to speak more on that?
I think I would just add, we're obviously going to want to focus on, what's going to really improve the health of rural North Carolina. We're going to also be focused on, like, where is there opportunity for really innovation and using technology. These are sort of the principles we're going to use to decide what's in and what's out. We're certainly going to want to choose those things that position us to get awarded the grant. And so we're going to look at how specific initiatives or proposals will, how they will land compared to the scoring metric that's laid out. So we are sort of developed the framework for sort of filtering all of our ideas through this sort of framework to help us land. And we don't know yet how many, but that's a way we're going to approach the number that we end up with.
Great. Any concluding remarks, Deborah, or anyone else? We have about a minute left.
I will just say thank you all for joining today. We appreciate your participation. Please note these key dates to remember. October 10th is the last date that we'll be accepting feedback. We will submit our application before November 5th and hope to hear from CMS at the end of the month. There's a QR code there that you can use to submit feedback, and then you'll see our website where you can continue to submit feedback to us via a survey. There are email addresses that are available as well, and you can certainly reach out to anybody who's been on the call today in a speaking role. Thank you all. We appreciate your participation.
Thank you.